TKIs, and then treatment in the more advanced disease setting. We will also have two panel discussions moderated by extremely senior and experienced medical oncologists. The second will to all of you for joining. This is data from the very recent Dlbcl publication, and you can see that in our country lung cancer forms the 4th common cancer. One more interesting thing is that the incidence and the prevalence, we expect about 72,000 new cases of lung cancer. Prevalence is a little more than that, and you can see that the incidence and prevalence are very close together. This is because this disease has a very high mortality. More than 60,000 patients of lung cancer will die each year. Here in this bar chart, you can see that lung cancer has the 4th highest mortality, and amongst all these cancers which you see, the blue bar is the bar of incidence, and the red bar is the bar of prevalence. You can see that the incidence bar and the prevalence bar are very close together in lung cancer. Just to convey to you that unlike breast cancer, oral cavity cancer, uterine cancer, this is a malignancy in which a very large percentage of patients who are diagnosed will die. And this is the leading cause of cancer death not only in the world but in our country also. It accounts for about 7% of all cancer deaths. If you include both the sexes, this goes up to 9%. And we have data from a couple of publications in India that EGFR, ALK, and PD-L1, at least these 3 biomarkers are tested in the majority of cases, even in our country. The pie chart shows you the same. Lung cancer, 4th commonest cancer. We know that the treatment of lung cancer world over and also in our country is driven by histology, also driven by molecular biology. Over the past 20 or 30 years, the emphasis has shifted. Most of our patients, 80% of our patients are adenocarcinomas, and about 20% are less squamous cell carcinomas being the most common. And you would also know that the EGFR mutated lung cancers in Asia and in India constitute between 30 and 40% of patients. So 1 out of every 3 patients will have the EGFR mutation. This is again data from Tata Hospital, Dr. Kumar Pravash and his group, and data from Delhi Rajiv Gandhi Cancer Hospital, Dr. Doval and his group. 2 very nice publications. Now, however grim the situation might appear to be, world over, this is the New England Journal publication in 2020, the incidence of lung cancer, these blue lines are incidence, and these brown or orange lines are the mortality. The incidence of lung cancer has been decreasing. This is primarily because of the aggressive anti-smoking efforts in the Western countries. But fortunately, the decrease in mortality is more than the decrease in incidence. So this is minus 3.2%. And between 2013 and 2016, in men with non-small cell lung cancer, the decrease in mortality was more than 6%. Similarly, also for women, 5.9%. And this has translated into increase in 2-year survival from 26% to 35% in males, and from 35% to 44% in females. This is again a recent publication, data from the National Cancer Registry Program published in the Journal of Global Oncology 2020, in which the projected incidence of cancer in India, lung cancer is over here, the cumulative risk is about 10% in males, 7% in females. In our country, till age 74, 1 in 100 people will develop lung cancer. Most of the cancer registries show an increasing incidence of lung cancer, both in men and in women. However, the stage distribution in our country, only about 10 to 20% have localized disease, about about a third, both in men and in women, have locoregional disease, and close to 50% have metastatic disease at diagnosis. So we are basically looking at advanced disease in the majority of our patients. However, some patients of early stage lung cancer are auto-diagnosed in our country, and the most important thing when you have a patient diagnosed with early stage non-small cell lung cancer is a proper preoperative workup. Please pardon me this should be preoperative workup. And one of the new tools for this preoperative workup or staging is endoscopic bronchial ultrasound. I have great pleasure in now inviting my batchmate and my very dear friend Dr. Suresh Gulwal. Suresh is Senior Professor and Head of Pulmonary Medicine at the SMS Medical College Hospital. I may also like to tell you that he is the past president of the Indian Bronchoscopy Society. So he is the perfect person to talk to us about EBUS in the preoperative staging of non-small cell lung cancer. Suresh, please welcome to this program. And I'm going to stop sharing my screen, and the screen is yours.
Thank you, Dr. Hemant, and thank you for inviting me to be a part of this webinar. And this is an interesting topic which I am going to present is in case of non-small cell carcinoma preoperative staging, whether the EBUS should be done in all cases or not. Now, a brief introduction about EBUS. It's a technique that uses ultrasound along with the bronchoscopy to visualize the airway wall and structures adjacent to it. It allows real-time guidance of the transbronchial needle aspiration of the mediastinum and hilar structures and parabronchial lung tube masses. So, with the bronchoscopy, you are EBUS. Now, radial probe is 60-degree views, so which are high phasing. Now, on the other hand, convex probe EBUS is having diameter of 6 target lesion. Continue taking aspirin. Phase number 1, which is supraclavicular lymph nodes, upper paratracheal, prevascular, retrotracheal, and lower paratracheal. These are the superior mediastinal lymph nodes. Aortic lymph nodes are subaortic, which is in the aortic pulmonary window, and paraortic lymph node, which is there in the ascending aorta. Inferior mediastinal nodes are subcarinal, paraesophageal, and pulmonary ligament lymph nodes. And these N1 nodes are hilar lymph nodes, interlobar lymph nodes, lobar lymph nodes, segmental and subsegmental. So there are 14 stations of the lymph nodes. Now, when you say normal mediastinum, when the CT scan shows absence of visualized mediastinal lymph nodes or presence of non-pathological size of the lymph nodes, that is less than 1 centimeter or sub-centimeter lymph nodes in the short axis diameter is not significant. Or on the PET scan, if there is no hypermetabolic activity, that is uptake is less than 2.5, less sensitive for the size which are less than 10 millimeters. So, if this situation there, you can say the normal mediastinum is there. Now, for the mediastinal staging is very important because N0 is the regional lymph nodes. No regional lymph nodes are involved. But if these blue lymph nodes shows the N1 metastasis, they are the ipsilateral peribronchial or ipsilateral hilar lymph nodes and intrapulmonary lymph nodes like lobar, interlobar, subsegmental, and segmental lymph nodes are enlarged. If in the red color, there are N2 lymph nodes where the ipsilateral mediastinal as well as the subcarinal lymph nodes are enlarged. And green shows the N3 lymph nodes, which has supraclavicular lymph nodes on the either side. Also, on the contralateral side, lymph nodes, if they are enlarged, involving the lobar, interlobar, and the most common lymph nodes which are involved are in the station 1, 2, 4, 7. These are the most commonly involved stations. So when the tumor is on right side, the N3 is very important. So first you will take the biopsy from the N3 lymph nodes, then N2 lymph nodes, and then N1 lymph nodes. Then you are going EBUS to DNA. Now, mediastinal lymph node status must be accurate as possible before understanding surgery with curative intent. Now, what are the modalities which you can assess the lymph node stations? The mediastinoscopy is the invasive procedure. With mediastinoscopy, you can assess access to the lymph node 1 to right, right and left upper paratracheal, this prevascular or retrotracheal lymph nodes, or lower paratracheal lymph nodes, and these subcarinal lymph nodes. With the extended mid-Nsclc, you can add to the aortic and para-aortic, subaortic and para-aortic lymph nodes. With the Chamberlain procedure or anterior mid-Nsclc, you can approach to the 5 and 6 number. To the VATS, which is another invasive procedure where you can approach to the superior mediastinal lymph nodes as well as the aortic lymph nodes. With the conventional TBNA lymph nodes, you can approach to the upper paratracheal, lower paratracheal, subcarinal, hilar, and lobar lymph nodes. USFN is advantage of USFN that you can reach up to the 8, the para-umbilical or para-ligamentous lymph nodes, the para-esophageal and para-ligamentous lymph nodes. Also, you can take the FNAC from the liver, from the celiac lymph nodes, or from the left adrenal glands. So, but EBUS TBNA is very important, where you can reach to the 1, 2, and in some cases you can also reach to the anterior part of the prevascular lymph nodes, in the lower paratracheal lymph nodes, the subcarinal lymph nodes, hilar, lobar, interlobar, lobar, segmental, and subsegmental lymph nodes can be approached with EBUS TBNA. Now, EBUS TBNA has a very good sensitivity in the various studies, ranging from 92 to 95%, and specificity is 100%, where the accuracy is up to 97-98%. Now, there are the various modalities where the comparison, and you see that VATS procedure, which is invasive procedure, has a sensitivity of 100%. Also, the EBUS is also a 100% sensitivity. The positive predictive value is also equal to the VATS procedure, and negative predicted value is also almost equal, the 96% with the VATS, while the 91% from the EBUS TBNA. But EBUS TBNA, if you combine with the EUS TBNA, then this negative predictive value also increases 96%, and also the sensitivity increases. Now, if you compare the EBUS TBNA from the mediastinoscopy, they are almost comparable, that whatever you get the sensitivity of mediastinoscopy, which is an invasive procedure, the same sensitivity is there with the EBUS, and also the negative predictive value is also low. But both techniques have similar performance of in the mediastinal lymph node staging in the lung cancer. Now, EBUS in the non-small cell carcinoma has a very important role for the collection of adequate sample of diagnosis, staging, genotyping, and immunohistochemical analysis. It's a fund, and European Society of Thoracic Surgery upfront surgery. So, current guidelines recommend proceeding to invasive mediastinal staging in almost all cases. Certainly, PET-CT positive results should be pathologically confirmed tumors there which is more than 3 centimeter, less than 3 centimeter, or radiologically negative positive, or when the invasive staging not needed in such cases, when the peripheral tumor means it is the tumor which is in the invasion is there, then invasive staging is not needed. Yeah, it is directly said that it is not fit for the surgery. But if the patient has abnormal mediastinal lymph nodes or central tumors, safe procedures with reported minor complications are less than 1% of cases. Now, what is utility of EBUS TBNA in clinical stage N0N1 energy? This is the study which shows that radiologic and hilar region N0N1 surgical extraction is the treatment of choice. Now, pathological upstaging has been documented in up to 35% of clinically N0 status by EBUS TBNA. So, upstaging has occurred. The most common lymphomas why comprising of 9 studies which demonstrated the sensitivity is.
Thank you for the opportunity to be here. I guess it's good evening there and good morning to us here. Thank you, Dr. Malhotra, for the introduction. Locational, almost all make sure that will be easy, but as you know, orange is automation. There's this in mind. Basic outline of what we're going to talk about. Background on lung cancer. I'll try to speed through that, given some of the background that's already been given. Surgical opinion on resectability, section assisted thoracoscopic surgery. So a lot of this is shared data between the U.S. and international survivors as related deaths are related to lung cancer in India, based on one of the previously the 20 large. Excuse me, the slide is trying to move me along. 200 of those cause more people. There, it also increases the number of cigarettes smoked per active. There is a significant history of patients continue to For this talk, we're talking more about stage 1, 2. There's some 3A in there, but I won't get into the 3A as there is some variability in just all stage teams are kind of. So referral to a surgeon to determine if medically operable. We pride ourselves in trying to determine that in many different objective ways. Stage 1 and stage 2, in my mind, there's no question for at least a minimum surgical consultation, just given the survival benefits and the data that's out there. Some bias over stage 3A, but I do also think that there is improvement in that, and surgical intervention, at least a consultation, is warranted. Patients who are active smokers, provided counseling and smoking cessation support. There is a decrease, as I suggested, in perioperative pneumonia, air leak recurrence rate. If you are able to get the patient to stop smoking. I know it's a lot easier said than done. How do we choose the selection for patients with lung cancer? There's multiple guidelines in the literature. A lot of this is that art versus science, but it revolves around two principles: fitness for surgery and operability. The fitness for surgery, things like age, what's logic, the Eastern one, which is not imperative. What does fitness for surgery mean? We know that perioperative name is 55, my elderly, but times the physiologic function is addiction. Frailty is a new area, option that most surgeons look at, and they're looking at a CAT scan or imaging of some kind. Types of the options are open, like we talked about, VATS, or this unfortunate name called RATS, but that's what it's called. To the side of the in SBI or operative, I'm sure. We want 40 things like pneumonectomies of FEV1. The percent is on the left, so the right lung is a little bit bigger than the left. The upper lobes on both sides, and I'll show you an anatomical slide very soon. About 25% of your ability to breathe. The middle lobe on the right side is 15%, and the lower lobes usually do about 20% of your ability to breathe, which is a ballpark number for the vast majority of patients. If in questions or concerns, there's things like a 6-minute walk test, a shuttle test, cardiopulmonary exercise testing, which can be done, but again, are more testing to help stratify patients who can be candidates for surgery. Perfusion scan is also used to quantitatively identify what I use for more repeat or redo operations or marginally compromised patients with respiratory issues to see if they can tolerate lung surgery. Ideally, you want the post-op FEV1 to be greater than 1.5 liters. This cannot always be done, and many times we're operating on patients where they have much lower post-operative FEV1, but again, that discussion with the patient for quality of what they want versus quantity is always imperative to happen. There's usually a hard stop at if the post-op FEV1 is going to be less than 800 mLs. This is something that came out of a lot of cardiopulmonary physiologic studies 50 years ago, and something that a lot of us still practice. There are those surgeons who do practice with patients who do end up with less than this. So it is a possibility to do that. But again, going back to the art, once a patient is selected for, which we'll get to that, but again, this is what a thoracotomy looks like on the picture on your screen right, I hope. And that's a right upper lobectomy. Lung cancer is rounding on the literature for the that are making significant progress, and those are slowly becoming 19 segments. These are just a picture out of Dr. Honda's group that talked about segmentectomies, surgical armament. I think that's operational. This is a segment that pick on lead, see morbidities, just do a time percentage, lymphadenectomy goal. You find a PET scan is done, PFTs are.
This is in classification, how the classification of the Basal lymphomas has emerged over a period of time, and what are the important aspects in the diagnosis of Basal lymphomas. We all know that there are more than 90 subtypes of lymphomas, and the prevalence is approximately 5 per 1 lakh in India, and they account for around 3 to 5% of all cancers in India. And we all know that the lymphomas are highly curable malignancies, and the cure rates approximately 80 to 90% in lymphomas. And we, from the ages, we know that the lymphoma is broadly classified into Hodgkin and non-Hodgkin lymphoma, and in the non-Hodgkin lymphoma, there is the classification that immature, that is the lymphoblastic variants, and the mature lymphomas. And in this session, we will be seeing majority on the mature B-cell lymphomas. And this is the broad classification how we differentiate between the non-Hodgkin and Hodgkin. And non-Hodgkin lymphoma is predominantly a disease of elderly, and it is the most common lymphoma, and it can arise anywhere in the body, and the occurrence is unpredictable, and the prognosis and wise it is not as curable as Hodgkin lymphoma, because we have a very good prognosis and high cure rates in Hodgkin compared to the non-Hodgkin lymphoma, and non-Hodgkin lymphoma is challenging to treat compared to the Hodgkin lymphoma. So these are the common B-cell lymphomas: the diffuse large B-cell lymphoma, follicular, mantle and marginal zone lymphoma, and the small lymphocytic lymphoma. So these are the various techniques how we diagnose lymphoma, right from the histology to the immunohistochemistry, and the molecular techniques like the FISH, the sequencing techniques helps us in identifying the cell of origin, and also the FISH techniques helps us to identify the subtype of lymphoma with accuracy. So morphology, we all know that the key in the diagnosis of lymphoma and the characteristic feature in the morphology is the diffuse effacement of the architecture of the lymph node, where in Dlbcl we see sheets of the large atypical lymphoid cells, and in follicular lymphoma we'll see the follicular pattern with centrocytes and centroblasts, and these two are the most common B-cell lymphomas we see routinely in our clinic. This is the classical Dlbcl, so where we see the centroblasts with peripheral nucleoli and minority of in the majority of the portion. In the minority, we see immunoblasts, and there are various subtypes of the Dlbcl, morphologically the centroblastic variant and the immunoblastic variant, and rarely the anaplastic variant. This is the follicular lymphoma. On the morphology, we see the follicular pattern, and based upon the presence of number of centroblasts, we divide the follicular lymphoma into three grades: the grade 1, grade 2, grade 3, where the grade 3 it typically behaves like a Dlbcl. And the mantle cell lymphoma, this is not as common as the Dlbcl follicular lymphoma, and there are various subtypes in the morphology like nodular type, blastoid variant, and these are the small to medium lymphoid cells with irregular nuclear configuration. So these are the other rare subtypes: the small lymphocytic lymphoma and the hairy cell leukemia, and the nodal marginal zone lymphoma. These are not that quite common compared to the Dlbcl and follicular lymphoma. And in the next few minutes, I will be taking through what are the important aspects in the Dlbcl which are important in the clinic. And although we see the morphology of lymphoma, the most important to accurately confirm the lymphoma is the immunohistochemistry. There are various immunohistochemistry markers which are specific to the lymphoma, so that we can diagnose the lymphoma with precision. So the common immunohistochemistry markers are the B-cell markers like CD19 and 20 and CD17 and whereas the markers which helps to differentiate in the low-grade lymphoma are the CD5, 10 and 23. So this is the classical immunohistochemistry pattern of Dlbcl, where the Dlbcl cells generally express the pan-C B-cell antigens as well as the common leukocyte antigen, the CD45, and expression of CD30 can be seen in the anaplastic variant of the Dlbcl, which is seen in the 25%, approximately 20 to 25% and associated with more favorable disease. CD5 expression is uncommon in Dlbcl, and the three characteristic markers which are needed to identify the Dlbcl are the BCL2 staining, BCL6 and the Ka67. We all know that Dlbcl is aggressive lymphoma, and the Ka67 is more than 40% always, and it may be occasionally more than 90% in few cases. So a majority of the cases, that is more than 70 to 80% of the cases, express the BCL6 staining, but the expression of the BCL2 in IHC is widely varied according to various publications. It ranges from 25 to 80%. So this is regarding the diagnosing the B-cell lymphoma, the Dlbcl, seeing the morphology, confirming it with IHC with the Ka67, BCL2, BCL6 and CD20. But over the past 5 years, there is a lot of changes in the Dlbcl, how to identify it, and is it all the Dlbcls behave as in the same pattern. And over the clinic and over the various studies, we have seen that all the Dlbcls doesn't behave similarly, and 30% of the patient relapse or doesn't respond to the traditional R-CHOP therapy at all. So this led to the digging more into the molecular changes and identifying the various pathways in the Dlbcl. The most important of this is the cell of origin, that is the identification of which origin of the cell of Dlbcl. That is that there are based upon the cell of origin, the Dlbcls or divided into the GCB, the germinal center B cell Dlbcl or the activated B cell Dlbcl. So the morphologically, the immunohistochemistry wise, they are different, and the prognosis wise and the behavior wise also they are different. So the first algorithm that developed was the Hansen algorithm, where the CD10, BCL6 and MUM1 were used for classification, and it has shown that the GCB subtype is comparatively better compared to the non-GCB, and the patients with non-GCB immunophenotype will behave very aggressively and has a very poor prognosis. Later on, refining the Hansen algorithm, many algorithms were proposed like Choi algorithm, Tally, and Notkunam, where different immunohistochemistry markers were identified, and the standard way to identify the cell of origin is gene expression profiling, but it is not available in majority of centers. So these algorithms of IHC were compared with the gene expression profiling and has shown the concordance rate of approximately 80 to 90% and can be widely used in our routine clinics so that we can identify the cell of origin with precision. So, and in the 2016 WHO update, it is proposed that it is acceptable to investigate the cell of origin based upon the IHC algorithms. What I have told, the CD10, BCL6, GZ1, LMO2 are important in GCB subtype, and MUM1, FOXP1, and CD138 immunohistochemistry markers are important to identify the ABC subtype of Dlbcl. So apart from the cell of origin, what are the other factors which are important to prognosticate and which are important in diagnosis in Dlbcl, or the identification of the MYC, either by IHC wise or by the FISH. So when to test for a MYC in Dlbcl is all Basal Lymphoma unclassified morphology, and those who have a blastoid morphology, and those who have a immunohistochemistry wise, so if MYC expression is more than 40%, they need to be mandatorily test for the rearrangement with a FISH break-apart probe. So we need to test for the MYC first, followed by BCL2 and BCL6. So various studies have shown that the MYC rearrangement can be seen in approximately 10 to 11% of the Dlbcls, and if they have a concomitant BCL2 and or BCL6, they can be classified into a double hit or a triple hit type. So apart from the MYC rearrangement, MYC expression alone can be seen in approximately 40 to 50% of cases of Dlbcl, but majority of them doesn't have a FISH rearrangement, and the FISH rearrangement is seen only in 5 to 10% of the cases. And apart from the published studies, we know that the double expressor or double hit lymphomas, that is the co-expression of MYC and BCL2 or BCL6 by IHC, or MYC and BCL2, BCL6 rearrangement by FISH, they are called as double hit. Either a double expressor or double hit, they tend to behave aggressively. And among these double expressor and double hit, we know that the double hit tend to do extremely poorly compared to the traditional Dlbcls without any MYC and BCL2 rearrangements. And we know from the published studies, we know that the double expression of BCL2 is more frequently observed in the ABC subtype, whereas the double hit thing is more common in the GCB subtype. So now, apart from the cell of origin, we do have two other subsets, that is the double expressor lymphomas and the double hit lymphomas. And these double expressor are by the IHC, that is the MYC expression should be more than 40% and the BCL2 expression should be more than 70%. And these are most common in the ABC. They have an inferior outcome, but not as poor as the double hit lymphoma. Double hit lymphoma, the incidence ranges from 5 to 10%, where we identify the MYC and BCL2 or BCL translocation by FISH, and they are more common in the GCB subtype of Dlbcl. And they have a very poor outcome with the standard R-CHOP therapy, and they need a more intensive therapies rather than a standard R-CHOP alone. So to conclude, how the double hit lymphomas are the 1/3 of the Dlbcls are they have a BCL2 and MYC expression by IHC, and the most of them are ABC subtype, and double hit lymphomas are most often GCB subtype. So apart from the aggressive lymphomas, the Dlbcl, other aggressive lymphomas which are close to Dlbcl are the Burkitt lymphoma and BCL lymphoma unclassified, and based upon the IHC pattern, we can differentiate the Burkitt from the Dlbcl. The Burkitt lymphoma is classically a CD10 positive and a BCL2 negative neoplasm, and MYC rearrangement is often more present in 98 to 99% of the cases of Burkitt lymphoma, and the Ka67 almost touches 100%, whereas the BCL2 expression is variable in GCB type of Dlbcl, and the MYC rearrangement is seen in only 5 to 10% of cases of Dlbcl. Coming to the other B-cell lymphomas, the most common subtype of B-cell lymphoma is the follicular lymphoma. We know that based upon the morphology of follicular pattern and the presence of centrocytes and centroblasts, we identify the follicular lymphoma, and the characteristic translocation we see in follicular lymphoma is 14-18. If we demonstrate it by FISH, we can confirm the diagnosis of follicular lymphoma. And in the recent WHO, there are various other entities which are proposed, like follicular lymphoma with blastoid morphology and the pediatric type. And these are the cases which doesn't fit well into the classical definitions, and they doesn't classically behave like the follicular lymphoma. And we all know that the follicular lymphoma grade 3 has slightly behaves like Dlbcl, and it has a low frequency of 14-18 translocation. And the other less common B-cell lymphomas are the mantle cell lymphoma and marginal zone lymphoma. And we know that the characteristic translocation associated with the mantle cell lymphoma is 11-14, which helps in diagnosing the mantle cell lymphoma, and the surrogate for IHC marker is the expression of the cyclin D1. So the mantle cell lymphoma expresses the pan B cell markers along with the CD5, which is classical in mantle cell lymphoma. And to differentiate it from the CLL, CD23 can be done, which is positive in CLL and which is negative in mantle cell lymphoma. So rarely in cases where in 10% of cases where the cyclin D1 is negative, SOX11 can help in the diagnosis of mantle cell lymphoma. So this is the proposed molecular pathogenesis, how the cyclin D1 and the SOX11 drives the pathogenesis of mantle cell lymphoma. So from NAB cell, the institutive mantle cell neoplasia starts, where the mutation of the IgG and the expression of the SOX11 drives the pathogenesis of mantle cell lymphoma, where unmutated and SOX11 positive B cell will become a mantle cell lymphoma, the classical, and upon acquisition of TP53 becomes a blastoid or pleomorphic mantle cell lymphoma. Whereas hypermutated and SOX11 and negative B cell lymphoma becomes a leukemic non-nodal mantle cell lymphoma. So other rarer subtype of B cell lymphoma is the marginal zone, where three subtypes are there: the nodal marginal zone, extranodal, which is more common; gastric maltoma is the most common of the marginal zone lymphomas, and the splenic marginal zone lymphoma. So we know that in the gastric maltoma, the characteristic translocation is 11-18. It has a diagnostic significance and also a therapeutic significance, that the presence of 11-18 translocation is associated slightly with the lesser responsive to the H. pylori treatment, and they need treatment with radiotherapy or chemoimmunotherapy. So these are the various immunohistochemistry markers which helps to identify the low-grade lymphoproliferative disorders. Of them, the most common are the Cd5 and Cd23. So Cd5 positive neoplasms are CLL and mantle cell lymphoma, and of them, to differentiate CLL and mantle cell lymphoma, we can do a Cd23, which is negative in mantle cell and positive in CLL, and cyclin D1 confirms the diagnosis of mantle cell lymphoma. Whereas in marginal zone lymphoma, the expression of the Cd5 and Cd23 is variable, and most often many markers may be absent in marginal zone lymphoma also. So coming to this is regarding the diagnosis. We take out the lymph node, we do a morphological examination. Based upon this, we do an immunohistochemistry, all express the B cell markers. Apart from that, cell of origin and the identification of the presence of or absence of MYC is important in Dlbcl, and identifying the double expressor status and double hit status is very important because they have a prognostic significance, and they also guide us to treat beyond R-CHOP in a case of Dlbcl. Apart from the Dlbcl, other common B-cell lymphomas are the follicular, mantle, and marginal zone lymphomas, where the follicular is the second most common lymphoma and the most common low-grade lymphoma, where we can diagnose by 14-18 translocation, and also with the CD10 and BCL2 expression on the IHC. Mantle and marginal zone are slightly less common. We can identify with the 11-14 translocation of cyclin D1 and SOX11 expression in mantle cell lymphoma. Marginal zone lymphoma, based upon the site and based upon the morphology, we can diagnose marginal zone lymphoma. If at all needed, we can identify with the help of 11-18 translocation. So coming to the classification, how the classification of the lymphomas has evaluated. Classification is the language of medicine, so that there is a uniform pattern of description of the lymphoma, so that the worldwide the incidence and the classification treatment wise there will be uniformity. So this is the need of the classification. So the classifying lymphomas has started way back in 1900s, but that was not that uniform, and everyone has proposed their own mechanisms. And the first organized classification was proposed by Rappaport in 1956. Later, the Lukes and Collins has proposed the classification in 1974, taking into the site of origin and the cell of origin and the state of transformation. They proposed a classification. Later, the Leonard has proposed upgraded the Thiel classification and has proposed the classification into a low grade and a high grade. And low grade were called as a lymphocytic lymphomas, and the high grade were called as lymphoblastic lymphomas. So this is the Thiel classification. And later, the to avoid the transatlantic differences in the classification between the European and American, a combined classification of real classification, that is the revised European American lymphoma classification, was proposed based upon the cell lineage and differentiation, taking into morphological, immunological, genetic, and clinical information. And later in the 2000s, the WHO came into the picture, and the first international consensus classification of hematological tumors was proposed. Later it was upgraded, and the recent one was the 4th edition, and they have updated the 4th edition in the 2016 and 17, and they take into account the morphology, phenotype, genetic, and molecular features into account while classifying the lymphomas. These are based upon the site, the primary mediastinal, primary CNS lymphoma. The Dlbcl has been dissected into multiple types based upon the cell of origin, and based upon the site, and based upon the infectious disease as etiology. We'll go through it. And this is the 2017 update of WHO classification, where there is a refinement of the diagnostic criteria, taking into account the morphology, phenotype, clinical criteria, molecular features, that is the various classification exam. For example, previously Burkitt lymphoma was a single entity. Now the Burkitt-like lymphoma with 11q aberrations was identified as a separate entity because it is not behaving as a classical Burkitt lymphoma. And infectious disease agents were added into the classification, like EBV positive neoplasms, HHV8 positive neoplasms. So they became a separate entities in the recent WHO classification. And early steps in the lymphoid neoplasms are added. Previously, follicular lymphoma was a single entity, and now the in situ follicular lymphoma and the in situ mantle cell lymphoma were identified as a separate diseases in the recent classification. So this is the in situ follicular lymphoma, and the partial and the in situ mantle cell lymphoma were classified as a separate disease entities in the recent WHO classification. And also association of the infectious disease are also, like the EBV positive LBCL and the extranodal nasal type, and the EBV positive T cell lymphoproliferative disorders of childhood, and HHV positive associated PEL, primary effusion lymphoma, and HHV positive Dlbcl were differentiated as a separate entities in the recent WHO classification. So these are the very clinically relevant profiles, the diagnostic criteria to refine the entities, and they have a prognostic and predictive significance. And if at all we identify the molecular profile and the molecular abnormalities, which will help in identifying a target, so that these actionable targets may further improve the outcomes in the lymphomas. So, for example, we know that BRAF and MYD88 has become a signature mutations of the high-risk cell leukemia and Waldenström microglobulin. So this is in a nutshell what has been updated in the WHO recent classification. The cell of origin has been mandated to identify GCB, ABC based upon we can use IHC and differentiate it. And the EBV positive mucocutaneous ulcer and EBV positive Dlbcl has become a not otherwise specified. And Burkitt lymphoma, other subtype like Burkitt lymphoma, like lymphoma with 11q aberrations as a new entity was added. And also the double hit and triple hit status were separated from the traditional Dlbcl, and they are designated as high-grade B-cell lymphoma with double hit or triple hit nature. So this is the traditional classification. And in the low-grade lymphomas, the follicular lymphoma was dissected, and the in situ and duodenal type were separated, and the pediatric follicular lymphoma was a new entity. So this is in a nutshell the newer update of the WHO classification. The refinement of the definitions and the diagnostic criteria and terminology was changed, like the in situ follicular and mantle cell lymphoma and GI T cell lymphomas, and pediatric types were separated from the traditional lymphomas. And early and indolent lymphoproliferative disorders like in situ neoplasias and indolent lymphoproliferative disorder of the GI tract were added. And relevance of the phenotypic, genetic, and molecular features were added, like the double hit criteria and triple hit, and the cell of origin like GCB, ABC type of lymphomas. So this is regarding the classification. Thank you.
Thank you so much, sir. So we've received a question on our Q&A.
Economic instability is a well-known hallmark of cancer.
Roughly about 50 to 60% get cured in the long term, but that essentially means that about 40% will not respond to R-CHOP therapy. So once you have a relapsed DLBCL, I think the first question that you look at is this patient transplant eligible or ineligible? If the patient is transplant eligible, both ways you give salvage chemotherapy. If they become PET negative, you would consider an autologous transplant. If they are PET positive, you could consider either an allo or clinical trials. And if they are transplant ineligible, there's a question about whether once they go into remission, whether you would do some salvage. The important thing to remember is that of the people who are transplant eligible and receive salvage chemotherapy, roughly only about 50% would proceed to a autologous transplant. Now, in terms of salvage chemotherapy, I think there's clear data to suggest that whether you use RDAP, whether you use RICE, or whether you use RGDP, there's no difference in terms of the outcome. So any of these chemotherapy regimens you can choose. And once you do that, if you do an autologous transplant, roughly about 50% will be cured. So we need to remember, if you start with 100 patients who need an autologous transplant, only 50 will reach an autologous transplant, and out of the 50, only 50% will be cured with an autologous transplant in the long term. But definitely compared to just giving chemotherapy alone, the PARMA trial showed that autologous transplant is better. EBMT had looked at doing allogenic transplants in diffuse large B-cell lymphoma. Initially, they looked at about 40 to 50% chance of cure, but I think the CABMTR data is little more accurate and reflective, where they have shown about 20 to 30% chances of cure whether you use non-myeloablative or myeloablative allogenic transplants. With the myeloablative, you had less relapse, but more non-relapse mortality, and with a reduced intensity, you had less NRM and more mortality. So ultimately, remember that we have reasonable number of patients who are relapse refractory. So what can we do for them? Is there any point in giving chemotherapy? The data, both with using R-GEMOX or BR, is about 20 to 30%, so it's not very useful. There is some recent data on the use of lenalidomide. So this was a study published about 3 years back, looking at lenalidomide alone in refractory DLBCL, 15 to 25 milligrams per day, and overall response rate of about 45%. Importantly, this response was seen mainly in the non-GCB type and not in the GCB. Similarly, in 2019, there was a study looking at ibrutinib at 560 milligram per day plus rituximab plus lenalidomide. It is a small study of 45 patients, but showing a overall response about 44 patients. So this means that there is a small group of patients which may do reasonably well with these drugs, and this is something that is available to us. But there are a lot of drugs or therapies which are not available to us, but which are available around the world. And what are they? And we can divide them into drugs, cell therapy, drug antibody conjugates, and antibodies. So among terms of drugs, the most important would be selinexor. Now, this is an oral selective inhibitor of nuclear export protein. Now, XPO1 is overexpressed in DLBCL, and if you inhibit XPO1, then there is increased accumulation of the tumor suppressors, and that leads to cell death and destruction of the tumor cell. So the SUDDLE trial, which looked at Dlbcl who have failed at least 2 to 3 lines of therapy, this is a drug given at 60 milligrams on day 1 and day 3 every week. And they had about 120 patients who had either failed 2 to 3 lines of therapy, and about 30% who failed an autologous transplant. And about 70% were refractory to the last treatment that was available. If you look at this data in terms of overall response, roughly about 30% showed an overall response. But importantly here, the GCB subtype showed a better response than the non-GCB subtype. Now, this is different from the other drugs which I've talked about earlier, where the GCP did badly, the non-GCP seemed to do well. So this is something we need to look forward in the future. This is actually approved by the US FDA in 2020 for the treatment of refractory DLBCL. The second is, of course, CAR T-cell therapy. I mean, all of you, I think over the last 5 years, you attend any meeting, you hear about CAR T-cells. This is the process by which you get it. You do a leukapheresis, collect the T-cells, then you induce it using specific constructs. I'll come to that. And then you expand it, then you infuse it back into the patient, after some chemotherapy. Now, these are the main focus antigen has been the CD19, and these are the CAR T-cell constructs which have been used in Dlbcl. This is what is called as abicaceptagene, Tisangelucel. These are the two major ones, Yescarta and Chimera, which have already been approved, and this is the new one. Essentially, the backbone is slightly different in terms of what is the transmembrane domain, and this is the first generation, second and third generation CAR. Now, most of these patients, you generally would give lymphodepletion to help enhance the cytotoxicity of these CAR T cells, and there have been different doses ranging from 2 into 10 to the power of 6 and varying doses which they have looked at. Like I mentioned, the lymphodepletion in the host prior to infusion of the CAR T cells helps in a proliferation of CAR T cells. But the problem with the proliferation of CAR T cells is the cytokine release syndrome, which occurs, which can either be in the first week, second week, or third week. Usually later down the line, it's usually associated with neurotoxicity. And as per US estimates, you spend $500,000 on the CAR T cell production, and you spend $500,000 on the treatment. So obviously, it is quite significant enough to cause a lot of problems. Now, if you look at this, just the summary of all the groups, this is the Zuma and the Juliet is the axisatabine and the Tisangelucel. Essentially, there is an overall response about between 50% to 80%, including 40 to 50% showing remissions. At the end of 6 months after a CAR T cell, only about 30% continued to show the remissions. And then this is data that was published looking at a long-term, a 2-year follow-up, roughly about 30 to 40% continued to remain in remission. So we need to remember that although CAR T cells would show a better response initially, there will be a group of patients that relapse. And so overall, we are looking only at 30-40% of long-term remission with a CAR T cell. Now, people are looking to see whether changing the construct helps, to whether multiple infusions of CAR T cell will be better than a single CAR T cell. And the third, which is going on now, is to look and see whether combining anti-PD-1 blocking antibodies will help in improving the responses. And the early data from the Alexander trial, where you add on pembrolizumab, seems to suggest that it is better in terms of the response, and importantly, it is better in terms of the reduction in the CRS and the neurotoxicity that occurs with CAR T cells. So this is something we need to look for in future. The other exciting group is the antibody conjugates, like you have gemtuzumab and the other drug inotuzumab. This is a drug called as polatuzumab, which is conjugated to anti-CD22 and which is also attached to this monomethyl auristatin. So those patients, those who are lymphoma cells which are anti-CD22 and CD19 positive, the antibody binds to it, it gets internalized, then MME gets released, which is a microtubule toxin that leads to apoptosis or cell death. So the initial trial looked at comparing bendamustine plus rituximab versus polatuzumab plus bendamustine rituximab, initially a total of 6 cycles at 21-day intervals, and essentially showing an improvement in the median progression-free survival and overall survival, importantly showing about a 45% overall response as compared to 10 to 15% with just chemotherapy alone. And what was also important was the fact that in both the GCB and non-GCB types, which is essentially the ones in the red lines, they did better than just chemotherapy alone. So it was useful in both of them. Now, it has been so exciting. And so in June 2019, the FDA actually gave approval for the use of polatuzumab. And now people are looking at actually using it along with R-CHOP in untreated Dlbcl, and we need to see what the outcomes are with that. There are numerous new monoclonal antibodies. One is Rituximab and Tafasitamab. Rituximab is basically a humanized anti-CD19 monoclonal antibody, and this is given as an infusion every 3 weeks for up to 1 year. They did this study, a phase 1, phase 2 study in patients who had failed at least 2 lines of therapy, and essentially they showed that about 40 to 50% showed response in Dlbcl, including 45% in the high-grade Dlbcl, which was mainly a complete response. So this is exciting data to look at initially, but we need to see, and the median duration of response for about a year. Safety profile was actually quite good. Only 10% had more than grade 3 adverse events, which included neutropenia and thrombocytopenia. The other important drug is Tafasitamab, which is again a humanized anti-CD19 antibody. But what is important is the FC portion has been engineered to both enhance ADCC and ADCP, and this is combined with lenalidomide to enhance the NK cell function, which would again improve on the tumor kill. So there was this study where they looked at the addition of Tafasitamab with lenalidomide, and they took patients who had failed between 1 to 4 lines of therapy, including 10% who had prior autologous transplant, and roughly about 40% showed a response. 50% showed a response, with about 40% actually showing a complete response. So in 2020, the FDA has actually granted accelerated approval for the use of this combination in refractory Dlbcl. Of course, neutropenia, thrombocytopenia, and febrile neutropenia, and its complications of pneumonia were the common complications seen in this group of patients. But this study was important because it seemed to suggest that there was a group of patients who would do reasonably well. And so this was the overall response, and this was with cell of origin. In ASH in EHA 2020, this data was updated. They looked from the primary analysis. Now from 17 months, it had gone up to 30 months. The overall response rates continued to be about 58% with a 41% of CR. So, and a median duration of response of 3 years. So it is something which is which you can look forward to, because this may be a good bridging therapy. Like blinatumomab, you have bispecific antibodies, and these are antibodies which bind to both CD20 and CD3. And the most important antibody among all of this is what is called as mosunetuzumab, which is basically a combination of CD20 with CD3. And the second important antibody is glofitamab, which basically consists of 2 CD20s along with 1 CD3. Now, essentially, this BiTE antibody will attach to CD20 on the target tumor cell and will attach through the CD3 onto T cells. This will then lead to transfer of granzyme and perforin to the tumor cell and causes lysis of the tumor cell. This is given as an infusion. There are now data on using it subcutaneous also every week for 3 weeks in a month. And it was given for roughly about 8 cycles, and this was a phase 1, phase 2 trial. In this trial, they essentially showed that, and important thing was that they had a group of patients who had failed previous CAR T cell therapy and then went in for the study. Roughly about 30% had a cytokine release syndrome with neurotoxicity about 40%, but majority had only grade 1 cytokine release syndrome. Otherwise, the main thing was neutropenia, fatigue, and hypophosphatemia. It was reasonably useful in refractory Basal lymphoma, and essentially about 38% showed response with about 20% in long-term remission. And this included about a 50% response in people who had failed previous autologous transplants. And importantly, if you look at patients who had previous CAR T-cell therapy, roughly about 40% showed a response even to that group of patients. So this is something which is probably useful even in patients beyond CAR T-cell where you want to look at treatment. So if you finally look at the treatment landscape, I think what is important is that just like how the drugs available for myeloma is increasing, I think there's an increased use of other therapies, which includes cellular therapy, which has been approved both in the US and Europe for CAR T-cell, the approval for tafasitamab with lenalidomide for refractory DLBCL, the approval for polatuzumab, and the fact that there are potentially other bispecific antibodies which are available for treatment which can occur in the future. With this, I'll stop and I'll be happy to take questions.
Yes, Dr. Biju, thank you so much for taking
the first subtopic actually. So rituximab maintenance in follicular non-Hodgkin's lymphoma. And I would like to address my questions here to Dr. Karan Kumar. So the first question, yes, Dr. Karan Kumar here. Hi. So the first question, next slide, please. So do all patients with follicular non-Hodgkin's lymphoma benefit from rituximab maintenance of the first-line therapy? Over to you, Dr. Karan Kumar.
Yeah. So the question is about rituximab maintenance after first-line treatment, right? So before I answer this question, we need to understand few aspects here. So about the disease per se, we all know that follicular is a lymphoma is a indolent neoplasm, and we treat them only in case of high-grade disease and if they are symptomatic. And even after remission, even we see relapses often in this disease category. So in indolent disease, because most of the patients survive for a longer duration, even with the disease per se. And the second point is the practical aspects here. So when the diagnosis is made and when we see the patient and discuss about the disease, the patient expects an endpoint in the treatment, So he'll ask us, so doctor, how long the treatment is going to be? How long I'm going to come to hospital? Will I be get cured of the disease? These are the very important questions patient will ask to us. So now the point would be, the best thing would be to cure the patient. But again, depends on the patient setting and the patient age, comorbidities, and the disease nature of the disease and the chemotherapy regimen which we choose. So usually the practical aspects are, will there be an endpoint in the treatment? The other aspect is how long the maintenance, or if suppose post end of treatment, post 6 cycles, or once the induction is completed. So how long the treatment is going to be? And when we explain about the maintenance in these patients, we have to tell them what the drug is about. So we have to convince them that this is a drug which partially affects your immune system, and it may predispose you to certain risk of infections. Then it's convincing the patient will be a little bit difficult. So these are the practical aspects. And coming to the question per se, usually if we talk about maintenance, I believe that there are two categories of patients where we think of maintenance. The one set of patients are the ones who have achieved complete remission. And the second set are the ones who have achieved partial remission. So if I have to choose personally rituximab maintenance in these patients, I will choose those patients who have partial remission, because logically that would help them prevent progression and at least prevent them from the further aggressive treatment later point. And we know the studies, the benefits and all. But personally, I would choose rituximab maintenance in a patient with a disease of partial response.
Thank you very much. So a couple of slides to back us in terms of where we are with regards to maintenance rituximab in follicular lymphoma and how did we get here. So the major landmark trial is the primer trial, where people were randomized to either maintenance or observation alone after having achieved a CR or a PR, as you have alluded earlier on, and with over 1,000 patients, and there's been a definite benefit with progression-free survival, time to next anti-lymphoma therapy, time to next anti-cancer therapy, but no difference in overall survival. And we now have an update from after nearly 9-year follow-up, and essentially median PFS is about 10.5 years in the rituximab arm and about 4.1 years in the observation arm. That's significant difference in PFS. An interesting thing is this is independent of age. Sorry, next slide, please. This is independent of age, sex, FLIPI score, induction chemotherapy, CR or CRU or PR. And one interesting thing is about 60% of people who have had rituximab maintenance have still not needed any treatment at 10 years. So, as you said, it entirely comes down to, are they in CR or PR? Are they clued in? Are they willing to continue treatment for another 2 years? Are they willing to afford the cost of it with an expense of slightly increased risk of infections for an essentially non-curable illness where we are looking to prolong the PFS, but probably not in terms of overall survival? Right, next slide, please. So this is your second question, Dr. Karan Kumar. A now 64-year-old male diagnosed as having stage 4A, grade 2 follicular non-Hodgkin's lymphoma with FLIPI high score, and who's received 6 cycles of RCVP with a good PR at end of treatment. At that point, he refused or declined maintenance treatment for one of the reasons you mentioned earlier. And 3 years later, he has progressive disease and is now treated with 6 cycles of bendamustine rituximab to a near complete metabolic CR on an end of treatment PET CT. Would you recommend maintenance rituximab treatment post bendamustine rituximab in this second line setting in this patient?
Okay. So here we don't know the reason why the patient declined, and the first therapy received was RCVP, which is not aggressive. And the second time he has received proper therapy of BR of 6 cycles, that too near complete metabolic CR. I would keep this patient on observation and follow-up, and then once he progresses and symptomatic, then I would think of therapy. I think here I'll postpone my decision of maintenance here at this point. Because he has received BR, effective therapy, I think I would wait here rather than going for maintenance.
Yeah, you're right. I mean, it's not a straightforward yes or a no here. Yeah. So would you have considered maintenance rituximab if he had a PR after bendamustine rituximab in this?
Yeah, definitely.
As opposed to a near CR? Yeah. Oh, yeah, that makes sense. And over the next few slides, it's going to show some data to see where we are in terms of maintenance after bendamustine rituximab or maintenance after second-line treatment. There's no prospective trial to show that rituximab maintenance makes a huge difference after bendamustine. In the gallium study, where there was a randomization between rituximab and obinutuzumab in combination with chemotherapy and maintenance with the same monoclonal antibody that was used at induction, there was definitely increased toxicity in patients who have had bendamustine, but that could potentially have been mainly because of the bendamustine alone rather than due to the monoclonal antibody. And a cross-trial comparison by Rummel, one of the German physicians, suggested that there's definite benefit after bendamustine, similar to that seen in the primer trial, where bendamustine wasn't clearly one of the chemotherapy arms. It was either RCVP or RCHOP or RFCM. So extrapolating that, there was definite evidence of some benefit with post-bendamustine as well. Next slide, please. So Hill et al. Have collected some retrospective data from multi-center American institutions. All of them were like fairly big tertiary academic institutions in the US, and collated data from about 640 patients. And this was a retrospective analysis, and they showed there was definite progression-free survival benefit, but that was limited only to the patients who have attained a PR and not to those who have achieved a CR. Next slide, please. And likewise, a meta-analysis of a few studies have shown that the substantial prolongation of PFS and also overall survival in relapse setting after reinduction, as in this particular patient. But none of the trials have actually investigated the role of second-line maintenance in somebody who's had first-line maintenance. So I think it's very difficult to answer the question. And clearly, there's no benefit of considering second-line induction in second-line maintenance in somebody who's had first-line maintenance and probably relapsed fairly soon, like within a couple of years after first-line therapy. And I'm sure everybody will probably agree that there's probably not much benefit for considering second-line maintenance in that setting. Whereas in the patients where they have not had first-line maintenance for whatever reason, maybe if they've had a PR or a CR, even after bendamustine therapy, we probably will consider second-line maintenance therapy. So with that, I guess we'll probably take some questions at the end of the session, unless somebody has anything burning right now. We move on to the second subtopic here. Next slide, please. So this is about rituximab maintenance in mantle cell lymphoma. And our panelist here is Dr. Varun Nair. Dr. Varun, are you here?
Hello. Yes, Dr. Rajesh.
Yeah, hi. Thank you very much. Yeah.
Hi.
So the first question here, Dr. Varun, is, next slide, please. A 61-year-old female with mantle cell lymphoma stage 4B, BP intermediate risk. She received 6 cycles of BR with a metabolic CR at the end of treatment. A fairly straightforward question. Would you give her maintenance rituximab for this lady, and if so, for how long?
Okay, thank you, Dr. Rajesh. So now we have a 61-year-old lady, stage 4 mantle cell lymphoma, BP intermediate risk, and she attained a metabolic CR after 6 cycles of BR. So I would prefer observation only, rather than giving the maintenance rituximab. If the induction regimen was used was the R-CHOP, then I would have used with much confidence that is to give the maintenance. Because till now, we do not have the solid data to use the maintenance rituximab even in follicular lymphoma or in mantle cell lymphoma.
Right. Yeah. I mean, I wouldn't say this area is actually a minefield or a very controversial area, but most of the times it comes down to individual preference and I mean, how much of a benefit as opposed to given the costs involved with maintenance rituximab therapy. Toxicity-wise, probably not a huge risk, but still, I mean, this is something we shouldn't undertake very lightly. So thank you very much, Dr. Varun. With that, a few slides on where we are with regards to maintenance rituximab in mantle cell. Most studies have shown an improvement in the duration of response, but again, like in the case of follicular, not much in the way of an improvement in overall survival. And a subgroup analysis from Maintaince trial by Rummel suggested that no additional PFS or an overall survival benefit after BR maintenance, after BR and maintenance rituximab. There's a European MCL study in the elderly population where people who have had maintenance rituximab after R-CHOP chemotherapy have showed a significant improvement in overall survival as well. I mean, especially in people who have had rituximab maintenance as opposed to people who have had interferon maintenance. So interestingly, about 60% of these elderly people who have had rituximab maintenance have not needed any treatment after 4 years of therapy. And in this particular trial, they have given maintenance therapy until disease progression. But that I'm pretty sure is not general consensus in terms of how we would probably consider maintenance rituximab in this particularly elderly group of people. So next slide, please. So a meta-analysis of 3 large RCTs have shown an improvement in PFS, but again, not an improvement in overall survival. And like in the follicular lymphoma, Brian Hill have shown from a large retrospective, multi-center retrospective analysis, they've shown that there is an improvement in overall survival, but only for those patients who have had a PR and not CR after bendamustine rituximab. So with regards to your take in terms of post-bendamustine, I guess there's not a clear yes or a no for maintenance rituximab in mantle cell lymphoma. With that, I'll move on to your next
Dr. Rajesh, may I interfere? Sorry,
sure,
may
yes,
I add?
Yeah, sure.
Yeah, in mantle cell lymphoma, actually, if the patient is not a transplant candidate, the best option to achieve a prolonged remission is to give induction with R-CHOP followed by the maintenance rituximab. But as you told, actually, the maintenance until progression is not practical in our setup. So usually, what I usually do is to give 2 years of maintenance, extrapolating the data from primary trial.
Yep, that's absolutely true. I think most of us would probably stick to 2 years maintenance as opposed to, until progression, because I think it's very difficult to deliver in our setting. You're right, yeah. So the second question I have for you, Dr. Warren, here is a 42-year-old male with stage 4B mantle cell lymphoma may be high risk and treated on the Nordic protocol with 3 cycles of maxi-CHOP alternating with 3 cycles of high-dose RSC to a metabolic CR, followed by consolidation with an autologous stem cell transplant. For this particular patient, would you offer maintenance rituximab, and if so, for how long?
Yeah, sure. So now we have a 42-year-old male, stage 4 mantle, then maybe high risk, and he was treated with intensive induction chemotherapy and underwent the stem cell transplant. So definitely I would give the maintenance rituximab for 2 years, that is every 2 months for 2 years, because we have evidence for that as per the LYSA trial. I would go for maintenance rituximab.
Yep, that's right. Yeah, next slide, please. So the evidence is from the French group data where they had 299 patients. Next slide, please. Who had 4 cycles of RDAP followed by an autologous stem cell transplant. And they randomized about 240 patients into either rituximab maintenance or no maintenance, and had a significant difference in PFS at 4 years, and very marginal, or if at all, no difference in overall survival as with the other trials. But in this particular trial, they're given rituximab maintenance every 2 months for 3 years. And again, there's probably no head-to-head trial to say whether you do maintenance for 2 years or 3 years, and with that extra year of maintenance offer any meaningful difference. So, but I think in our setting where cost constraints and visits to the hospitals do make a big difference in terms of logistics and price, I think it's very reasonable to offer them a monthly maintenance for up to 2 years. Thank you very much, Dr. Warren. Moving on to the next subtopic, and our panelist for this one is Dr. Subbiah Ramanathan. Dr. Ramanathan, are you here?
Yes, sir. Yes, sir.
Sure. So the discussion here is about toxicities and arguments against rituximab maintenance. So with this, I address the first question to you, sir, right?
Yes.
Next slide, please. So the next slide, please. So we have a 60, sorry, can you get back, please?
Yeah.
Previous one, yeah, sorry. So we have a 63-year-old female with follicular non-Hodgkin's lymphoma, commenced on BR, and 15 days of the first cycle, she was admitted with the pneumonia, and 10 days after cycle 3, was admitted with pyelonephritis, and with a bit of difficulty, she completed 6 BR with reduction in the bendamustine doses, and she only had day 1 as opposed to day 1 and 2 for the 4th, 5th, and 6th cycles. And they achieved a good PR at her treatment and was commenced on maintenance rituximab therapy, but after the first cycle, developed a viral sounding lower respiratory tract infection followed by secondary bacterial pneumonia. So my question to you here, sir, is would you continue maintenance for this patient? And should she have actually been started on maintenance in the first place, given the history of infections of the first few cycles of bendamustine rituximab? Over to you, sir.
Yes, sir. She is an elderly female, and she has already had 2 major infections requiring hospitalization, one being pneumonia and other pyelonephritis. So in this scenario, I would continue maintenance, especially after she has got another hospitalization for infection management after the first maintenance itself. And moreover, she more than 60 years, and she has received BR. She has achieved a very good partial response, and especially in when I would weigh toxicity before considering maintenance for her.
Yeah, that's correct. I mean, the fact that she had two fairly significant infections in the first 3 cycles itself should have, made us think that she probably shouldn't have had maintenance rituximab in the first instance, and probably no point in continuing. The data comes from PRIMA in terms of there was an increase in grade 3 and 4 adverse events, but not any increase in the number of deaths, though there was a slight increase in the number of infections after the rituximab arm, as opposed to the observation alone. And the Maxima trial looked at the safety in about 500 patients across different countries, and there's definite evidence in terms of real-life safety with rituximab maintenance. But this is something that we shouldn't really approach with casualness. Next slide, please. Because there are, potentially serious side effects, however rare or uncommon they are. Next slide, please.
So, but in our setup, especially in elderly patients like this, we have to consider costs also. So, one episode of febrile neutropenia might cost a lot for management.
Rajesh sir, your mic is muted. Rajesh sir, can you hear us?
Sorry, it looks like I probably muted myself for a minute or so. Sorry, can you get back to the previous slide, please? Yeah. So, a few things with regards to, some of the toxicities associated with rituximab maintenance, hypogammaglobulinemia, which may be more of a problem with CLL rather than non-Hodgkin lymphoma. And PML is something, however rare it is not something we need to forget. And there have been several reports of PML happening even in the non-malignant setting, like after ITP and autoimmune hemolytic anemia. And one particular thing I've come across as well is delayed and potentially very difficult to treat and unpredictable autoimmune neutropenia after rituximab therapy. So these are some of the toxicities that we should all be wary of and not take maintenance rituximab too lightly. Next slide, please. So this is my second question, Dr. Ramanathan. A 51-year-old male with a 4A follicular non-Hodgkin's lymphoma treated with 6 RCVP to a PR, followed by 2-year maintenance rituximab therapy. And within 12 months after completion of maintenance, he progressed and was treated with 6 cycles of BR to a very good PR. Is this a patient in whom you would consider second-line rituximab maintenance in somebody who is at first-line maintenance and relapsed within 12 years after first-line maintenance?
He has progressed quite early, within a year, almost in a year. I would discuss with him, and then, though there is no strong data.
Dr. Ramanathan, are you there?
Yeah. Can you hear me, sir?
Hello. Yeah, I can hear you, sir. Yeah, go ahead.
So he has progressed in a year. So after 6 BRs, he has got a very good partial response. And we know from the data that after the relapse setting, the maintenance has got a survival benefit. But in the standard upfront setting only, there is a prolongation in the PFS, not in the OS. So I would consider if you're keen to follow up here, sir.
Yeah, that's absolutely right. And somebody who's relapsed within 2 years of maintenance, I guess, is not likely to do as well given the POD 24 data. But somebody who's relapsed within 1 year of maintenance, I'm sure most of you would agree that we wouldn't consider second-line maintenance for this patient. Thank you, Dr. Ramanathan. So next slide, please. So our next panelist is Dr. Mithun John. And I would like to address a few questions about how best to schedule rituximab maintenance. Right. Over to you, Dr. Mithun. Are you there, sir?
Yeah, I'm here. So regarding the schedule of rituximab
Mithun, are you there?
Yeah, I am here. Am I audible? Hello?
Yes, Mithun sir, you're audible.
Yeah.
Dr. Mithun?
So regarding the rituximab maintenance schedule, so if I've decided to give rituximab maintenance, so I would prefer in follicular lymphoma, mantle cell lymphoma, if I've decided to, hello?
I can see that he is.
Rajesh sir, are you able to hear my audio?
Hello?
Mithun sir, you're audible. I'm not sure why you're not audible to Rajesh sir.
I think there's some internet problems over there. That's
sure.
Correct, sir.
Yeah.
Correct.
Yeah, I got you now. So I can hear you loud and clear, Dr. Mithun. Yeah, sorry, I don't know what happened there. So my first question to you, next slide, please. Next slide, please. Yeah. How do you schedule your maintenance in your follicular and mantle cell lymphoma patients, either in your first line or second line setting?
Yeah, sure. So we have already discussed regarding the pros and cons of receiving rituximab maintenance. And if you decided for maintenance rituximab, I would prefer to give it every 2 monthly. So in follicular lymphoma, what I usually follow is 2 monthly for 2 years. If the patient is willing to come. So they have decided for maintenance therapy. So I would prefer, whether it's in follicular lymphoma, mantle cell lymphoma, to give it at 2 monthly intervals, at least 8 weeks. If the patient is not able to come every 2 monthly, at least 3 monthly.
Yeah, I mean, absolutely right. I mean, most of us would probably do 2 monthly because most of the evidence is from 2 monthly rituximab. But again, there's no head-to-head comparison between 2 months versus 3 months. So I think it all downs to individual preference and logistics. I've seen a few patients treated at Vellore. I mean, I'm sure Dr. Vijay might be able to chip in at some point in the question and answer session because I think I've seen a few of them receiving every 3 months. So I guess it's mostly down to individual preference and logistics as opposed to a definite a 2 month or a 3 month regime here. So my next question is, how long how long do you offer maintenance in follicular non-Hodgkin's lymphoma?
Means I usually offer for 2 years. Seeing the prima data also, I think 2-year maintenance is sufficient for follicular non-Hodgkin's lymphoma.
Yeah, I'm pretty sure everybody would be in agreement with that. And we don't have any evidence from anywhere to say that any maintenance beyond that will actually make a meaningful difference. And even with 2-year maintenance, we've seen from Prima that at 10 years, only about 60% of them have actually not needed any treatment. That's pretty impressive result. So any maintenance beyond 2 years probably is unlikely to make any difference. So my next question is, how long do you offer maintenance in mantle cell lymphoma?
That's going to be a tricky question, actually. So in mantle cell lymphoma, usually we tell that to give it, if you are giving R-CHOP or RCVP, to give it beyond progression, up to progression. So until progression is going to be a bit difficult. So when I explain the patients, most of the patients won't be allowing to go for infinite duration of treatment. So I usually give it for around 2 years.
Yeah.
Maximum 3 years, not more than that.
Yeah, that's exactly. Yeah. So the data is from one of the elderly German trials continued until progression, which, as you and the speakers earlier have alluded to, is very difficult to do in our setting. And 3 years, the data is from the French group post autologous stem cell transplant. So I guess most of us would agree that we'll probably continue maintenance for 2 to 3 years for most of our mantle cell lymphoma patients, but probably not indefinitely. And so there's no head-to-head comparison for any of these in terms of whether you do 2 monthly as opposed to 3 monthly, whether do 2 years versus 3 years, or whether do 2 years versus until progression. So that was, short and sweet. Thank you very much, Dr. Mithun there. And I would move on to the last topic here. And our panelist for this one is Dr. Sadvik Raghuram. Next slide, please. Dr. Raghuram, are you there?
Yes, sir, I'm here.
Yeah, thank you very much. Yes. So this is, I think we're probably dealing with a slightly premature or an imaginary scenario here, but I guess it won't be long before we probably will get subcutaneous rituximab in India as well. So I'm going to start off with an imaginary scenario where let's say we do have subcutaneous rituximab available in India. So next slide, please. So this is a 73-year-old lady with 4A follicular non-Hodgkin's lymphoma treated with BR2A, good response, and is on maintenance rituximab and has completed 4 infusions so far. But given the current pandemic scenario, she calls up and says, if there's any chance, given that subcutaneous rituximab is available, would getting it at home would be an option. So this is an imaginary scenario. Assume we do have subcutaneous rituximab, and we have a trained nurse who's able to go to the patient's home and deliver it at home. So what are your thoughts, sir?
Yeah, so she's a 73-year-old female who's achieved CR to rituximab and bendamustine. So presuming that the patient wants to continue with maintenance rituximab and not stopping it, subcutaneous rituximab has a good data, and it can be offered to the patient. The thing is, it is not only the efficacy wise, but even the adverse event profile is more or less similar with IV rituximab, except the local injection site reactions. Otherwise, the neutropenia and all those things are more or less similar. And there were like other few studies also done, which suggested that because of the ease of administration at the time, the patient preference was more for the subcutaneous formulation rather than IV formulation. So considering the COVID situation and presuming the patient wants to continue rituximab, I would definitely ask her to continue with subcutaneous rituximab.
Dr. Rajesh? Sir, are you there? So I think Dr. Rajesh is facing network issues. Can I request, or if the panelists have any questions for our speakers, or if the audience have any questions for our panelists, you can please put it in the Q&A box or the chat box, and till Rajesh sir comes back, we can probably take those questions.
This is Biju here. So I think Rajesh was just asking about our practice. We use only once in 3 months. That is more in terms of logistical issues. But, and I was just trying to pull out, there is one publication in 2015 where they looked at the patients in the PAMA trial who had either 2 months or 3 months and showed that the toxicity in those who had every 2 months was higher than those who had every 3 months.
So I just caught the last bit, Dr. George. Thank you very much for chipping in. I don't know what happened there again, and I seem to have disappeared off the radar and then back again now. So thank you. I mean, so so most of your patients at Vellore would probably be on 3 monthly maintenance.
Correct.
Is that correct, sir?
That's correct.
Okay.
That's correct.
Yeah. Okay. Yeah. Makes sense. Yeah. So sorry. Before I disappeared earlier, the data from Spark, Sabrina, and Sawyer have initially shown non-inferiority of subcutaneous rituximab compared to the intravenous rituximab. Next slide, please. So with that non-inferiority evidence, I think subcutaneous rituximab has been approved both in Europe as well as in the US. Initially for non-Hodgkin's lymphoma, and then for CLL in Europe, and then simultaneously in the US. And a fixed dose of 1400 milligrams is used in follicular lymphoma and Dlbcl. Whereas for the CLL patients, where they get 500 milligram per square meter from second cycle onwards, there's a 1600 milligram subcutaneous version available. So the subcutaneous solution had to be concentrated by 12-fold. So that means, I think it's a very concentrated solution, and then the absorption may not be that great. So what they've done is they've added in recombinant hyaluronidase to the rituximab to facilitate better distribution and absorption. So there's two fixed dose versions available, 1400 milligram, which is used in non-Hodgkin's lymphoma, and 1600 in CLL. Next slide, please. So there's some analysis done more or less like post-marketing or post-use, and in terms of cost and benefit and all of that, coming from the Canadian SCUBA study, and then MAVIS, and then PRIFMAV, which was like a patient preference questionnaires. And all of them have confirmed that there's significantly less preparation time and much significantly less administration time. So the subcut is administered over 5 minutes, whereas as we know, the intravenous version can take anything, even from a rapid infusion from about 90 minutes to 3 to 4 hours intravenously. And because of a fixed dose combination, there's less wastage, and much less in the way of infusion reactions, though even though patients do get subcutaneous rituximab, they invariably get the first dose as an intravenous infusion, and only from the second dose onwards they get it subcutaneously. And as we have noted from these trials, that there's much better patient satisfaction given much less time spent in the hospital. So the France and Canadian data have suggested that significant cost savings, but I think coming to the Indian setting, that may not really be possible, because most of the rituximab that we use are actually generics. And when we lay our hands on the subcutaneous version from Roche, it would still be in patent. And unless they price it very, very competitively, I guess the pricing will be high. And we'll certainly be looking at how much of a difference does it make in terms of cost-benefit analysis. Because, certainly when I moved back from the UK to India, most of the patients there were getting subcutaneous rituximab from cycle number 2 onwards. But when I was recently chatting to some of my colleagues in Scotland, they were saying that they've now moved back to doing intravenous rituximab because the benefit of savings with regards to generic rituximab IV as opposed to using subcutaneous rituximab was so much that they thought, moving away back to intravenous rituximab meant a lot of cost saving to the National Health Service. So when it is launched in India, we need to look to see how competitively priced it is. And there may certainly be an outpatient who would probably be willing to afford, however, the price is. But otherwise, I think we'd probably be looking at how much with regards to saving the chair time and how much expensive it is before we'll probably roll on to the general population. So with that, I think I've completed pretty much on time. So probably have a couple of minutes for questions and answers. And maybe some of them have already been answered.
The use of targeted therapies in the adjuvant setting. And that's what I'm going to talk about in the next few slides. We know that about 1/3 of our patients have a driver mutation. This could be the EGFR sensitizing mutation, ALK mutation, or one of the rarer mutations. And we now have targeted therapies available for all these mutations. The chunk of the pie which has unknown driver mutation is only 1/3 now. And I think as our techniques for molecular testing becomes better, this chunk of the pie will become smaller and smaller. When I started oncology some 30 odd years back, this chunk of the pie used to be almost 50%. So it's already down to 1/3. And maybe when I stop oncology in another 5-10 years, it'll be gone. Let's hope for that. So this is the current treatment paradigm for patients who have a molecular marker positive advanced non-small cell lung cancer. For the patient with EGFR mutation positive, we have first generation, second generation, third generation agents now. We have first line treatments, second line treatments, and third line treatments now. And today, for the purpose of our webinar, we are going to focus on patients who have the EGFR mutation. And as I already told you, the prevalence of EGFR mutation is similar across stages, whether you have stage 1 disease or stage 4 disease. In India and in Asia, about 1/3 of these patients will have the EGFR as a driver mutation. Now, these are the generations of the anti-EGFR tyrosine kinase agents available to us. First generation gefitinib, erlotinib, second generation afatinib, dacomitinib, and third generation osimertinib. And fortunately, all these agents are available to us for use in our country. And if you compare all these agents, this is what you see. You have the first generation agents over here. Blood-brain barrier penetration is the maximum for osimertinib, and the third generation agents, drugs which target the T790M mutation, again the third generation agents are significantly superior to the first and the second generation agents. And this is data in metastatic non-small cell lung cancer. I'm not going to spend too much time on this. We have a separate talk on this. But just to tell you that just with an oral pill with these tyrosine kinase inhibitors, whether it be imatinib in the IPAS study, you can have a progression-free survival of about 9 to 10 months. Same with erlotinib. The Lux lung studies are with afatinib. You can increase it by 2 more months to around 11%. Archer studies is with dacomitinib. You can go to about 14 or 15 months. And with our third generation agents, osimertinib, you can cross a year and a half of progression-free survival in the metastatic setting. What about the use of the EGFR TKIs in the adjuvant setting? There have been several studies with erlotinib, with gefitinib, but in most of these studies, even though there is a hint that progression-free survival may be increased, there has been no benefit in terms of overall survival, and because of this, these agents are not approved in the adjuvant setting. Now let's talk about this, very important trial, which is known as the Adjuvant trial, use of osimertinib, the third generation tyrosine kinase inhibitors in patients with resected EGFR mutated non-small cell lung cancer, published in the NEJM in 2020. This was the design of the study. It was a global randomized double-blind phase 3 study. All patients had to have the EGFR mutation, either exon 19 deletion or L858R mutation. And they were substratified by Asian versus non-Asians. Here are the inclusion criteria for you. 1:1 randomization, patients to receive osimertinib 80 milligrams once a day versus placebo, 300 plus patients in both arms. The drug had to be given for 3 years or till recurrence or till unacceptable toxicities. The primary endpoint was investigator-assessed progression-free survival. And here are the groups for you, and you can see that 300 plus patients in both the arms, and pretty evenly matched for age, sex, smoking status, Asian, non-Asian, WHO performance status, CNS metastasis, the histology, the 2 different types of EGFR mutations, very, very well balanced. And almost 60% in both the groups had received adjuvant chemotherapy. And here are the results for you. Disease-free survival, you can see this massive difference. The blue curves are with osimertinib and the red curves are with placebo. And here is the hazard ratio for you. Very, very rarely in medicine or in oncology, you see a hazard ratio of 0.17 and a very significant p-value. This is patients who have stage 2, stage 3A disease, and these are the curves for patients who have stage 1B to 3A, the whole subgroup. And both of them, you can see a very significant difference. Obviously, a very big separation, very early separation of the curves, and a very significant hazard ratio. This again was in the original NEJM publication, CNS disease-free survival. again significantly better with osimertinib versus placebo, which was kind of expected because of the blood-brain penetration of the drug, and again a hazard ratio of 0.18, which is very, very impressive. Then if you do analysis by stage, in the early stage, stage 1B, the separation of the curves is much less, and if you progress to move to stage 3A, then the difference, the difference between the two curves is very significant. Hazard ratio in 1B being 0.5, and hazard ratio in 3A being as low as 0.12. Overall survival, the data is still immature. Median has not been reached in both the arms, but you can still see that the hazard ratio is beginning to show a difference. And again, we are waiting, very eagerly waiting for overall survival data with this study. Here is the subgroup analysis, the forest plot for you, and then again you can see that across subgroups, age, sex, smoking history, particularly impressive hazard ratio 0.10 for smokers, Asians, non-Asians, and again maximum, most impressive hazard ratio for patients who have stage 3A. And please note here that patients who have exon 19 deletion, the hazard ratio is much more impressive as compared to the hazard ratio for the exon 21 mutations. And patients who receive adjuvant chemotherapy or do not receive adjuvant chemotherapy, then again a little more benefit for patients who do, but also significant benefit, hazard ratio of 0.23 for the patients who do not receive. What about toxicity? Osimertinib over here, placebo over here. Very few cases of a grade 3 and more toxicity. Some diarrhea, some skin and nail changes can be seen, but otherwise the most of the toxicities is grade 1, 2. So again, not a very difficult drug to tolerate. In this particular study, quality of life was also assessed, and the tool used was the SF36 score. And just to summarize for you that the SF36 component scores was maintained over time in osimertinib arm, and there was no clinically meaningful difference when compared to placebo. So again, no significant compromise in the quality of life in the arm receiving osimertinib. And again, deterioration of quality of life, again, in more than 80% of patients in both arms, the quality of life scores were maintained, and there was no difference between the osimertinib and the placebo arms. So with this data, the FDA approved osimertinib as adjuvant treatment for non-small cell lung cancer with EGFR mutations in December of 2020. And I may also want to add that the same indications have been approved by the Drug Controller General of India in our country also. A few further studies after this publication, this one was presented in the ESMO virtual, highlighting the CNS recurrence in patients in the two arms. And here you can see that disease-free events, distant recurrence or death were only 11% in the osimertinib versus 46% in the placebo. And most of the recurrence in the osimertinib arm were local and regional, while most of the recurrences in the placebo arm were distant recurrences and CNS metastases, which we know are much more difficult to manage as compared to local or regional differences. So the drug osimertinib does make a significant impact in the systemic spread of the disease. Here, particularly impressive, there was only one CNS recurrence versus 10 in the placebo arm. And this is again extremely important for our patients. This is highlighting the same 1% versus 10% osimertinib versus placebo. And CNS progression-free survival was much better as compared to the placebo. hazard ratio of 0.18. There was another interesting presentation in the recently concluded World Lung Cancer Conference in the subgroup analysis in the patients who received adjuvant chemotherapy versus who did not. And here you can see the numbers in stage 1B, 2, 3A, 26, 71, and 80% of patients received adjuvant chemotherapy. And the benefit of osimertinib with regards to improvement in progression-free survival was maintained whether the patient received adjuvant chemotherapy 89% versus 49%, or the patient did not receive adjuvant chemotherapy. And this is the hazard ratio for the same. So the take-home messages for my talk: patients who have stage 1B to 3A EGFR mutation positive lung cancer, disease-free survival was significantly longer in the osimertinib arm as compared to the placebo arm. Recurrence patterns is different in the patients who receive it. Osimertinib in the adjuvant setting, there is less CNS metastasis and less systemic metastasis as compared to the placebo. So adjuvant osimertinib is equally effective in patients who receive adjuvant chemotherapy or who do not receive adjuvant chemotherapy. Quality of life is not horrendously impacted with osimertinib and is maintained. And I'd like to highlight one more time that adjuvant use of osimertinib in the EGFR mutated population is approved in several countries, and it is also approved in our country. So with that, I'd like to invite you all to the panel discussion, and I'd like to invite the moderator of this panel discussion, my very dear friend